Thank you so much for joining us for today's webinar. Today we'll be talking about the intersection of Medicaid managed care and school-based services. My name is Jean O'Connor, and I'm the director of the Medicaid School-Based Services Technical Assistance Center. So today, during the webinar, again, we'll be talking about Medicaid managed care. We'll go over some important background information and talk through considerations for state Medicaid agencies. We're also really delighted to have a panel here today and participants from states to engage in a discussion. After that, we'll have some time for questions and answers, wrapping things up, and then adjourning. During today's call, we really want to make sure that everyone on the call has the opportunity to understand the benefits and considerations for local education authorities and managed care plans in establishing partnerships to deliver school-based services. We'd like for you to be able to identify the state Medicaid agency's role in monitoring compliance with the managed care requirements and encouraging partnerships with local education agencies and managed care plans. And then last, to talk through and consider best practices and lessons learned from states that have established strong partnerships between their local education agencies and managed care. We'll also be discussing primary care and some other important things during the call. During the call today, as all of you know, we're really here because of the bipartisan Safer Communities Act. It was signed into law almost a year ago and includes a number of provisions to increase access to Medicaid-funded school-based health services, including mental health services. And one of the important provisions of the Act was to ensure that there was information given to state education agencies and local education agencies on how to ensure payment for Medicaid-covered school-based services, and to establish interagency coordination between state agencies and provide technical assistance to state Medicaid agencies and education agencies. So I'm really delighted to turn it over now to Michaela Vine and Selena Pargas, who are a part of our Technical Assistance Center, who will get us started on discussing the intersection of school-based services and managed care. Michaela?
Thank you, Jean. So this slide provides a high-level overview of action steps to help educational agencies recoup reimbursement for school-based services, as well as some key stakeholders who will implement these steps and program documents that are needed to guide school-based service programs. In the past few webinars, we've walked you through how to gather and review data, build a coalition of stakeholders, disseminate decisions and information, and approach program documentation for reimbursement. During today's webinar, we will add another key player, managed care plans or MCPs. As we discuss the role of MCPs, we will be focusing on state-specific administration and direct service guidance that can help increase access to school-based services. As a quick refresher, managed care is a healthcare delivery system intended to help manage cost, utilization, and quality of care. Medicaid managed care provides for the delivery of Medicaid health benefits and services through contracted arrangements between state Medicaid agencies, or SMAs, and MCPs that accept a set per member per month payment, also known as a capitation payment for these services. By contracting with various types of MCPs, states can reduce Medicaid costs and better manage utilization and quality of services. Currently, most states use some form of managed care to deliver services to Medicaid beneficiaries, and more than 80% of children in Medicaid are enrolled in an MCP. There are three main types of Medicaid managed care arrangements. These include comprehensive risk-based managed care organizations, limited benefit plans, such as prepaid inpatient health plans and prepaid ambulatory health plans, and primary care case management. Most state Medicaid programs offer some form of comprehensive risk-based managed care, which generally provides all acute and primary medical services. Some programs also cover behavioral health and long-term services and supports. States can also choose to contract with MCPs for some benefits, but not include other benefits that will instead be provided through fee-for-service or limited benefit plans. Limited benefit plans allow states to contract with MCPs for a subset of benefits, such as behavioral health services, or services for a particular subpopulation, such as children in foster care or state custody. Limited benefit plans may also be used to provide services to fee-for-service enrollees, managed care enrollees, or both. A smaller number of state Medicaid programs use only primary care case management or a combination of primary care case management and comprehensive managed care. Enrollees in these programs are assigned to a designated PCP who is paid a monthly fee to assume responsibility for care management and coordination. Typically, SMAs negotiate with providers to deliver services to enrollees, either on a fee-for-service basis or through fixed periodic payments. As we mentioned on the previous slides, states can decide which Medicaid benefits are included in their managed care program and which services are not included. For example, in some states, MCPs provide physical health as well as behavioral health services, while in other states, behavioral health services are provided in some other way, for example, through the state's fee-for-service program. Other benefits commonly excluded from managed care programs are non-emergency medical transportation and care coordination or management services. As you can see on this map, currently only 3 states, California, Oklahoma, and Tennessee, include all school-based service benefits in Medicaid managed care. An additional 6 states include some school-based service benefits in managed care, such as behavioral health services. It's important to note that regardless of whether a state includes school-based services in their managed care program, common school-based services, such as EPSDC services, including rehabilitative services, are eligible to be reimbursed by the SMA. Even though children may be enrolled in a managed care plan, these services can be reimbursed by the SMA if some or all school-based services are not included in the MCP's contract. In states where school-based services are included in Medicaid managed care, LEAs must contract with MCPs to receive reimbursement for services provided to enrollees. For example, Tennessee requires that MCPs contract with LEAs seeking to provide medically necessary services in school settings. As I mentioned in the previous slide, some states include certain school-based services in managed care, but cover other school-based services through fee-for-service. For example, Minnesota includes non-IEP services in managed care, while IEP services are reimbursed through fee-for-service. Regardless of whether school-based services are included in managed care, there are several regulations governing states and MCPs, presenting opportunities to coordinate with LEAs in support of these regulations and effective delivery of care. For example, 42 CFR 438.208 requires MCPs coordinate their enrollee services across all settings, including schools. In the next section, we'll review some of these regulations and provide examples of how states can work with MCPs and LEAs to address them. Before we move on to the next section, we'd like to get an idea of how school-based services are covered by your state's Medicaid program. Please use the Slido link to tell us whether A, your state does not include school-based services in Medicaid managed care, B, your state includes school-based services in Medicaid managed care, C, your state includes select school-based services in Medicaid managed care, or D, your state does not utilize a Medicaid managed care delivery system. All right, let's see what we got here. All right, responses are coming in. It looks like in most cases, we are seeing that your states either do not include school-based services in Medicaid managed care or include select school-based services in Medicaid managed care. Give this a minute to even out though. All right. Well, thank you all very much for providing responses. I'm now going to turn things over to my colleague Selena to talk some more about general considerations for SMAs.
Thank you, Michaela. As Michaela mentioned, we'll now be diving into our next section to present some general considerations for SMAs and thinking about the intersection of school-based services and Medicaid managed care. As a reminder, the Individuals with Disabilities in Education Act requires public agencies to make a free, appropriate public education available to all eligible children with disabilities. The services identified on a child's IEP must be provided at public expense and without no cost to parents and legal guardians. Medicaid is generally the payer of first resort for these services as described in 34 CFR section 300.154. SMAs must ensure that they and their MCPs work with SEAs and LEAs so that children can access Medicaid services both under the child's IEP and as medically necessary outside of the school. First, it is important to recognize that there are multiple benefits for building strong partnerships between SMAs, LEAs, and MCPs. Most importantly, well-coordinated care and strong partnerships can help children receive medically necessary services and contribute to participation in school and overall physical and behavioral health. For SMAs, these partnerships can promote improved access to healthcare services, helping SMAs achieve coverage goals for children and adolescents. For LEAs, working with MCPs can reduce time spent on administrative issues, such as denied claims, and improve revenue flow, both of which help create more time for LEAs to provide healthcare and improve health outcomes for students. These partnerships can also help MCPs ensure improved health outcomes for enrollees and promote more efficient and effective program management. Finally, LEAs can provide MCPs with data to inform quality measures and improvement processes, both of which are part of Managed Care Plan's broader strategy to comply with regulations requiring care coordination. We will now dive into how to encourage these strong partnerships. CMS Regulation 42 CFR 438.66 outlines SMA oversight responsibilities to ensure that MCPs adhere to contracts. Therefore, it is important that SMAs are on the same page as their MCPs, communicating actively to guide the direction of Medicaid managed care and in outlining the role schools play in providing physical and behavioral health services to children. SMAs can also help to facilitate strong and mutually beneficial partnerships between LEAs and MCPs. SMAs should consider how LEAs can be engaged to support states' own federal Medicaid managed care requirements. For example, states are required to develop and implement a beneficiary support system to assist beneficiaries both before and after enrolling in an MCP. For this reason, SMAs can and should engage LEAs in their BSS system to help families of students with complex healthcare needs understand managed care plans and their options for filing appeals and grievances if services are denied. In addition, the recently released Medicaid program, Ensuring Access to Medicaid Services Final Rule, directs states to establish a beneficiary advisory committee to allow for direct feedback to state Medicaid and CHIP programs on benefits and service delivery. SMAs should be engaging schools in these advisory committees. States must also develop and monitor a managed care quality strategy for assessing and improving the quality of managed care services. As mentioned previously, LEAs can play a valuable role in providing data that MCPs will need to document progress towards quality measures, including the child core set measures, which will be mandatory for state reporting starting in 2024. Finally, states are required to identify and address health disparities. LEAs can help states reach children with health-related social needs, like transportation challenges. Services delivered during the day can help beneficiaries receive care without relying on a caregiver to take time away from work. SMAs should also consider how their contracts with MCPs can be used to establish stronger relationships with LEAs. MCPs are required to coordinate care and services for enrollees across settings. Because schools play a critical role in delivering medically necessary services, information must be shared with MCPs and community providers. Care coordination can also help young people access comprehensive health services and address social factors such as housing, food security, and transportation. For example, California requires that each MCP have an MOU in place with all LEAs in its service area to facilitate cooperation and collaboration between an enrollee's PCP and the LEA in developing an IEP or IFSP. The MCP must also provide case management and care coordination for enrollees. MCPs must make their best effort to conduct an initial screening of each enrollee's needs. School-based providers interact with students daily and are well positioned to identify students' needs and then implement appropriate screenings. MCPs have the opportunity to leverage screening approaches that are already occurring in schools. For example, Colorado passed legislation that created a 6th through 12th grade mental health screening program to identify risks and provide resources and referrals. Additionally, some states require that MCPs involve beneficiaries in service design either as a form of stakeholder engagement or by establishing an advisory committee. Schools are particularly well positioned to share information with MCPs regarding the needs of their students and communities. For example, Tennessee requires that MCPs submit an annual stakeholders and education engagement plan for involving stakeholders such as students, parents, or legal guardians, SEAs, LEAs, and individual providers. Great. We will now take a moment to answer the following Slido question, which should populate on your screen. How can MCPs use LEA provided data to support quality improvement initiatives and metrics? Is the answer A, calculate and report core set and other quality measures, B, assess service access and use, C, identify and address health disparities, or D, all of the above? I'll give a minute for folks to answer. So far, it looks like you've selected all of the above. Again, I'll give another minute. And if you're having any trouble accessing Slido, there is a link in the chat. Great, okay, well, so far, it looks like you all are answering all of the above, which is correct. The answer is D, all of the above. These are all examples of ways that MCPs can use the data provided by LEAs to support their quality improvement initiatives, including quality measurement. Great, thank you all for answering, and we can go ahead and move on. In this next section, we'll talk more about considerations for states who include some or all school-based services in Medicaid managed care. We have discussed the benefits of SMAs, LEAs, and MCPs working together. Now let's talk about some specific considerations for states that include school-based services in managed care or plan to add school-based services to managed care. In states that include some or all school-based services in managed care, each LEA must contract with MCPs to become a network provider and receive reimbursement for school-based services from the MCP. In addition, an LEA school-based providers may also need to enroll with both the MCP and the State Medicaid Agency to receive Medicaid reimbursement. However, this requirement does vary by state. It is important to note that LEAs may need to contract with multiple MCPs. This can be the case in districts where multiple MCPs are operating or in districts where students are enrolled in more than one MCP. For example, if a student is enrolled in an MCO and a behavioral health plan, and the school plans to seek Medicaid reimbursement for physical health screenings and one-on-one counseling, the LEA must contract with both MCPs. In thinking through the full universe of MCPs that LEAs may be working with, it's important to consider which services are typically delivered in school settings in your state and which will be covered by Medicaid. This may include occupational therapy, physical therapy, speech therapy, and counseling services. In the next few slides, we'll talk about considerations for SMAs and thinking through how the state, its managed care plans, and its LEAs can work together, and how the guidelines for these partnerships can be reflected in managed care contract language. The first category of considerations relates to provider enrollment. When developing MCP contract language, the state should consider how LEAs can fit into the approach that MCPs will use to enroll providers in their networks. The state should also consider whether LEAs and school-based providers can help the MCP meet their network adequacy and availability of services requirements. In some states, only the LEA and not each school-based provider is required to enroll with Medicaid to receive reimbursement. In these states, the LEA will appear on the claim while the individual school-based providers will not. In the state's managed care contract language, it should make its expectations clear for how MCP should contract with LEAs and school-based providers. For example, Tennessee's master managed care contract language states that MCPs can require that school-based providers be participating providers in the plan's network to receive reimbursement on the plan's standard fee schedule. Another category of considerations relates to service access. SMAs should consider and reflect in managed care contract language whether prior authorization from MCPs is permitted for certain services that are provided in schools. For example, speech therapy, occupational therapy, and physical therapy. One challenge noted by some families is that children receiving services in school in accordance with their IEP are being denied access to similar medically necessary services outside of school on the grounds that these services are received in school. States can use contracts with managed care plans to clarify expectations around access in these situations. For example, North Carolina's master managed care contract notes that a plan cannot deny a prior authorization of services based on a student's IEP, and notes it may use the IEP to support a decision that a student requires active treatment. It is also important that providers receive guidance on how to correctly document services so that insurers understand why a child may require certain services both within and outside of the school setting. For example, if a child's IEP indicates they need OT at school to support participating in classroom assignments, and the child's pediatrician prescribes OT with a community provider to help them with activities of daily living, Both the school and community providers must clearly document the medical necessity and goals of the OT services to receive reimbursement. As discussed earlier in our presentation, regardless of whether the student is receiving services in school pursuant to their IEP or receiving free care services, managed care plans are still obligated to coordinate care between the school and community setting. Another set of considerations for SMAs relates to data reporting. As we discussed previously, one benefit of partnership between LEAs and MCPs is improved access to data needed for quality reporting, and MCPs are required to maintain a health information system to capture this information. When SMAs are determining managed care contract language, they should consider how LEAs will be required to submit service data to MCPs. For example, California's managed care contracts require that all providers, including school-based providers, submit claims and encounter data. The MCP is then responsible for the completeness and accuracy of provider-submitted data, regardless of contracting arrangements or reimbursement methodology. Keep in mind that this data reporting is normally covered in an MCP contract, but in states where the LEA isn't part of the MCP network, a different type of data sharing agreement might be needed. Finally, SMA should consider whether incentive arrangements will be used to reward managed care plans that are in line with performance targets. These incentive arrangements can be used to encourage MCPs and LEAs to work together to provide services in schools. For example, in California, the Medicaid agency uses incentive payments to Medi-Cal managed care plans that meet outlined goals and metrics tied to targeted behavioral health interventions. Okay, so before we transition to our panel discussion, we have one final Slido question for you. Is each LEA required to contract with only one MCP? Is the answer A or B no? Sorry, A yes or B no? Give folks a moment to answer. So far, it looks like most of you are answering no. A couple more seconds. Okay, so far it looks like a majority or all participants have voted no, and that is correct. In districts where students are covered by multiple MCPs and LEAs and its school-based providers may need to contract with each plan to receive reimbursement for all services delivered to students in that district. Okay, I will now pass it over to my colleague Michaela to introduce our state panelists.
Thank you, Selena. So we are thrilled to be joined today by the following panelists from California and Tennessee. So first from California, we have Autumn Boylan, the Deputy Director for the Office of Strategic Partnerships at the California Department of Healthcare Services. Also from California, we have Sherry Coburn, the Division Director for the Comprehensive Health and Medicaid Programs at the San Joaquin County Office of Education. Sherry is also the Executive Director Consultant for the California School Nurses Association. And from Tennessee, we have Sean Smith, who is the Director of Managed Care Oversight at TennCare. So thank you all so much for joining us today. We are very grateful for your time. And to our audience members, as a reminder, throughout the discussion, please feel free to submit your questions through the Q&A. We'll be keeping track of the questions raised to the panelists, and we will hold some time for responses at the end of today's discussion. Great. So we have several questions that we'd like to discuss today with our panelists. First, it would be very helpful if each of the panelists could provide some context on your state's Medicaid managed care landscape and how it intersects with delivery of school-based services. So I'm wondering if Autumn, would you like to speak first on the landscape in California?
Sure, happy to. And thank you so much for including California in today's webinar. Good afternoon, everybody. So in California, based on our most recent waiver program, we have a 99% Medicaid managed care population in our Medicaid program. So most of our members of all ages are enrolled in a managed care organization and receiving care through the managed care organization. However, we do also have a carve out for our specialty mental health services programs and substance use disorder services programs. So our managed care organizations are responsible for providing non-specialty mental health services to enrolled members with mild to moderate mental health conditions and symptoms. And our county behavioral health delivery system is responsible for providing mental health services to individuals with severe and persistent mental illness, to young people who have multiple system involvement, as well as all of the substance use disorder services through our drug Medi-Cal and drug Medi-Cal organized delivery system waiver programs. We also, as part of our most recent waiver, which we call CalAIM, or California Advancing and Innovating Medi-Cal, have established some procedures to try to make it easier for people to get access to mental health and substance use disorder services by creating a no wrong door approach in California, so that regardless of acuity, if particularly a young person goes first to their managed care organization, they should get the help and care that they need. And there's screening tools to help determine if services would be more appropriate through the county delivery system and vice versa. These, I think, are important context for where we're going in terms of thinking about school-based services specifically. In 2021, as part of Governor Newsom's Master Plan for Kids' Mental Health, we launched the Children and Youth Behavioral Health Initiative in California, which is a $4.7 billion investment to address the youth mental health crisis in California for our young people. And as part of this effort, a lot of that work is focused specifically on enhancing and expanding access to school-based services, not only for our Medicaid population in the state, although of course very much included, but this effort is really a multi-payer, all-child, whole child approach. So it's also inclusive of our commercial health plans and disability insurers. And a couple of really important pieces that we're moving forward, and I'll talk about more in future questions, is one, we had a program called the Student Behavioral Health Incentive Program, which was a managed care incentive program to incentivize our managed care plans to partner with local education agencies in every county to build relationships between the LEAs and our managed care organizations. We also are launching a new reimbursement infrastructure in state statute. We now have authority to require our managed care organizations and commercial plans to reimburse schools for the provision of school-linked mental health and substance use disorder services. And so really focused on strengthening that relationship between our MCPs and LEAs through these multiple programs. And there's other pieces as well, including a contract requirement that will go live in January of 25 to require the managed care plans to enter into an MOU with LEAs. But that's kind of the outline of where we're focused through this larger initiative. We are really focused on expanding access to school-based services and reimbursement through our managed care organizations.
Thank you, Autumn. That's a lot to lay out for us, and that was a super helpful description of everything that's going on in California right now. So we'll be asking you some more questions about that. But first, let's turn to Sean. Do you want to tell us a little bit about the managed care landscape and how it interacts with school-based services in Tennessee?
Sorry, I was on mute. Good afternoon, everybody. Very happy to be here today. So here in Tennessee, and as previously mentioned, the state of Tennessee's Medicaid program, we're completely carved in. So all of our managed care organizations, we have a total of 4, manage the students' school-based services. And so what we've kind of been focused on is, and beginning back from as early as 2018, when I kind of started, was to kind of look at how we could expand some of these services. Currently, we only reimburse for those school-based services that are in the student's IEP or nursing services that are in the IHP. For behavioral health services, those services are billable with whether or not they're in the student's IEP or not. We also require that these services be ordered by the student's PCP or treating provider. For behavioral health services, this is a little different, where it's required by has to be an independently licensed behavioral health clinician who recommends these services. So again, looking at, we rolled out a strategic plan initiative at the beginning of the year, where we're looking at some ways to expand these services outside of the IEP, including what we've already done with school nursing services, and also looking at ways that we can improve the how LEAs bill for these services, and looking at ways that we can minimize some of those barriers. And one of the things we've rolled out is the LEA pilot. And basically what that's doing, and this is based on feedback that we've gotten from LEAs, that a lot of LEAs, in order to bill for these services, it really requires them to have a billing vendor to do it. And just because navigating through this wilderness of Medicaid, right? So last year we implemented the LEA pilot to kind of to identify one LEA that was currently not contracted with TennCare or with our MCOs, and kind of walk them through this whole process of getting the Medicaid ID number, and then contracting with the MCOs and subsequently billing for those services. And so that LEA is Alcoa City Schools in East Tennessee, and they have just completed that step with one of our MCOs, and now they're going to move to the next one. And we've already been identifying some really good information that have been blind spots for us on up until this point, that we're going to use in addition to other feedback we get to determine ways that we can improve the overall experience, the billing experience, the contracting experience for LEAs moving forward. And with the effort of trying to increase the number of LEAs that are contracted with our Medicaid program now, which at this point, out of 145 school districts, only about 40% of the LEAs are contracted with our MCOs.
Great, thank you very much, Sean. And we will be asking you a little bit more about that process in a minute. I'm going to turn next to another question. I think it would be really helpful for our audience to hear more about how your states have helped establish relationships between LEAs and managed care plans. Sherry, from your perspective as someone representing an LEA, would you like to speak first and tell us about how this has gone in California?
I pulled a Sean, sorry about that. So we know that children do not leave their healthcare issues at the school's front door, right? And so in looking at that, that context of it, early on at SJCOE at the San Joaquin County Office of Ed, we were able to establish a partnership with our managed care organizations using the current model. In that we did become a network provider at our educational system, because we do have mental health practitioners. We have registered credentialed school nurses that are mental health providers. And we know that a lot of times children will present somatically before they even recognize it being a mental health issues. And even kids with chronic health disease, asthma, diabetes, there's a lot of mental health issues that play into that, coping, strategizing. And so when we started working early on with our managed care organizations, we began to build that partnership, and also then talking about health information exchange, because obviously managed care organizations have HEDIS measures. Schools do a lot of screening. Schools can provide school-based vaccination, and managed care organizations need immunization rates, for compliance. And so it really did become a partnership early on. We also worked with our public health officer in San Joaquin County Public Health. So we've really tried to build and enhance those partnerships, because we have one common goal, and that is to ensure the health and wellness of our children and family in our county. We know that there's 5.8 million children in California, with 62% free and reduced lunch rates. In my own county, we have 154,000 children with free and reduced lunch rates of 66%. We know that there's high mobility between children, and so a lot of times they will move. 36% of kids report moving 7th graders 2 or more times in the past year. So that when you take a look at that, the health plans will have where the children are going because they have that information, forwarding addresses. Schools often have that as well. So we really do see it as a partnership and helping one another build and support children's health.
Great. Thank you so much, Sherry. And Sean, I'm wondering, you've told us a little bit about your work to get LEAs and managed care plans connected and help with those contracts, but can you tell us a little bit more about how this has gone in Tennessee? Anything else that you think might be helpful for others to hear about this work?
Absolutely. So I think, what we learned early on is that our MCOs needed to be nudged, so to speak, to kind of more engage with their LEAs. And I think really because when you're talking about LEAs, and I've said this before, I mean, they're like an atypical provider. And so they really don't know a lot about billing, which is the reason why they usually contract out for that. And so I think that what we've had to do, we've had to work with our MCOs to really engage with the LEAs. And so one of the ways we did that was with this stakeholder in education engagement plan. And so that was effective the first of the year. And what we've already been hearing some really good feedback from what the MCOs are doing. So we've got one MCO that's actually going out and doing a needs assessment and working with LEAs in our 3 different grand regions to identify what those specific needs are from the LEAs and trying to figure out how they can use that to kind of improve the billing process. And so they've already, I was just speaking with one of our MCOs today, and some of the feedback that they've received from some school nurses around billing barriers that they're going to use to kind of impact the claiming and policies based on some of that feedback. And another thing that good feedback for TennCare is that was that our process for LEAs getting registered to get their Medicaid ID number is kind of confusing. And so we're going to need to work on that. But as far as contracts go, we've been getting feedback from some time about some LEAs and how they have challenged or have concerns with our contract, our base agreements, the MCO's base agreements, because they see that these are more geared towards, medical providers, and LEAs are not the typical provider. So we're actually starting to look at that as well. Again, with the purpose of trying to improve the overall billing and claiming experience for these LEAs, to make it more appealing for them to contract and provide these services.
Well, that's very positive to hear, and it sounds like I think your lessons learned will be very helpful for people to hear about who are in the audience today. We are actually
Michaela?
doing pretty well. Yep.
Yeah, Michaela, I also wanted, I have to credit Autumn and her team, because at the Department of Healthcare Services, they have done a great job with onboarding schools and MCO teams together. They hold, frequent meetings, onboarding, Q&A sessions, and admittedly, it's a difficult thing because it's a new system that's being implemented. But DHCS has been very receptive to input. And so we really are very grateful for the partnership. I can't thank her team enough.
Thanks, Sherry. And that's great to hear that. Shout out to Autumn. Autumn, we're doing pretty well on time. Do you have anything you'd like to add here, or we can just keep moving if you don't?
Sure. I mean, thank you, Sherry. I would just say that it's a work in progress. And, I was recently speaking at another event, and it was actually an education-based event by my colleagues with the County Offices of Education. And on our table, there was a tent card that had a quote. It said, and I'm paraphrasing a little bit because it was a couple weeks ago. It said, "No significant change can happen without significant relationship." And I think that the point that Sherry just made, which I really appreciate, is that relationship building and the effort that takes is time consuming, but so worth it. And it will help get you to a better state of readiness, of system integration, of collaboration to be able to support our members, our young people in schools, and making that investment, while also challenging sometimes, is absolutely worth the time that all of the parts of our system are putting in. It's not just the State Medicaid Agency, the county offices of education. We have 1,100 LEAs in the state, and we have all of our managed care organizations, commercial plans. They're all participating in these learning sessions together so that we can build a better system for all of California going forward.
Thank you, Autumn. We're going to shift gears now and talk a little bit more about data. So it would be great to hear from our panelists about how you've worked with managed care plans to improve quality metrics and how data on school-based services has factored in, if at all. So Autumn, do you actually want to tackle this one first?
Sure. So we in California have a pretty robust multi-pronged strategy to improve quality metrics through a series of learning collaboratives that focus on key areas with our managed care plans in our Medicaid program. So we're focusing on improving access to children's preventative services. We're having regular meetings with the plans to share best practices. There's a regional technical assistance collaborative with state staff, as well as, of course, where appropriate, considering enforcement actions, corrective action plans, and penalties when the plans fail to meet our minimum performance level, which is the 50th percentile for Medicaid, as well as, we have numerous value-based payment programs to reinforce performance on quality metrics and health equity metrics. In terms of specifically the school-based services component, I mentioned earlier that we are including in our managed care contracts requirements for our managed care organizations to better coordinate care and enter into a memorandum of understanding with the LEAs in their service areas in 2025. We're also thinking about how we close some of those other gaps around children's preventative services, childhood immunizations, and other factors as we think about expanding school-based services into the future. So right now we're really focused on the behavioral health piece, but we'll really be building out this infrastructure that we're starting to develop through the Children and Youth Behavioral Health Initiative to think more long-term in terms of how we close these gaps. And then, of course, as with any new initiative, we are conducting an evaluation of the effectiveness of this new huge program. So we'll be looking at, are we increasing access? What does utilization look like? Are we improving on timeliness? Are we, reducing poor health outcomes for our students across the state? And so really focused on, that end result of we're doing this to improve outcomes for our kids.
Great. Thanks so much, Autumn. Sean, do you have any thoughts that you'd like to add from your experiences in Tennessee?
Sure. I mean, as far as our quality strategy goes, it looks a lot like what the state of California just described, but with the exception of one of the things that we are not doing is we really don't have a really good way to factor in school-based services and data. And so as a part of our the school-based services strategic plan is something that we're looking at as well. And beginning with just looking at how we currently share data with other agencies, including our Department of Education, and how they, subsequently exchange data with the LEAs. But we really want to find a way that we can use that data to develop, the appropriate metrics to be able to measure those. And I'm hopeful that we can get that, at least get something moving around that in the beginning of the third quarter.
Great. Well, we'll look forward to hearing more. Thank you all so much. We're going to move on now to our last question. So we have some time for questions and answers at the end. I think it would be, we've already talked a little bit about some of the challenges that you've addressed and in some cases overcome, but if there's anything else that you think it would be helpful for folks to hear about the challenges or barriers that you've encountered in establishing and implementing these processes, I I think that would be really helpful for our audience, as well as just any pieces of advice that you have for other states that are embarking on this work. Autumn, would you like to take this one first for California?
Sure. I will say, anytime folks are working on building new relationships across systems where there's different languages, different ways of acting, schools are not healthcare entities. They're education entities that provide healthcare. And so it's really a culture shift in taking the time to build those relationships, like I said in the previous responses, immensely important. We can't just assume that everybody will understand typical healthcare language. And I don't mean understand from a perspective of the words that don't make sense, but we have complicated systems in healthcare. And there's complicated systems in education, and we have to figure out how to untangle all of these and learn about each other's infrastructure and programming and goals, because ultimately we all do share a similar goal in making sure that our children are well and thriving and achieving academic success. And so, we got to break through some of those natural barriers that exist in our siloed systems to break down those silos and really figure out how to work together. I would just say also, it is immensely challenging to figure out, how to get local education agencies that don't have any experience with Medicaid billing, let alone billing commercial health plans, to figure out how to do that. And so I think Sherry can talk about some of the ways they've done that previously at the local level and trying to figure things out kind of on their own. But also as part of this new initiative, we stood up an infrastructure to support our health plans and our local education agencies. So we're contracting at the state level with the State Medicaid Agency with a third-party administrator who will do all of that provider management. So all of the credentialing of the school-based providers on behalf of the plans, oversight on behalf of the plans, so that the schools don't have to be subjected to credentialing by all of the various plans independently and oversight by all of the plans independently. That TPA, though, will also serve as a claims clearinghouse to do that benefit coordination and figure out which plan is responsible for payment of the claim, so that schools don't have to figure out and navigate different claiming procedures with all of the different health plans too. So we've really tried to establish some infrastructure at a state level to help minimize some of the administrative burdens and complexities that naturally come with these relationships.
Thanks, Autumn. And actually, let's stick with California for a minute. Sherry, any last words that you want to add here about challenges that you've encountered and addressed, or tips for others?
Well, I think having worked in a medical setting, hospital setting, and home health, and now working in education, you're right, that it is a systems language piece. So it really is about hand-holding and being a service-oriented organization. We're here to serve our county offices. We're here to serve our districts. And so really walking through the process. It's not to say that we haven't experienced a lot of challenges and barriers. There have been, but it's just stepping back, looking at, who can I connect with to talk, can I call Autumn? And Autumn's reached out to CSNO and the school districts and the county offices of education to be able to solve this problem. Enrollment in credentialing. School districts already credentialized, make sure their people are credentialed and possess the proper licenses. But the MCOs may not recognize that. And we do fingerprinting and background, so there's a lot of stuff that goes into that. But moving into the managed care organizations, they may not have that information or that frame or context. So I think it's just trying to do really creative problem solving, solution seeking, so that we can bump it up to the next level.
Thank you so much, Sherry. We are getting to the point where we should probably shift to some Q&As. And actually, I'm thinking that I can ask a question that will let Tennessee get in some last words. And also maybe you could respond to this one. So the question that we got is whether the panelists could speak to issues with coordinating services across schools and other settings, and the extent to which children are denied services outside of school, that appear duplicative and how these states are addressing these issues. Sean, would you be up for responding to this one first?
Sure. So this is actually an issue that I'm aware of, and it isn't an issue for Tennessee, and that's just because the only service that we require prior authorization for in schools is ABA services. And I think that some states where this is a problem, and I don't know, it could be wrong, but it's probably with those services that are being prior authorized. And so that isn't really an issue for us. And it hasn't even been an issue for ABA services, but something that, you know, we are aware of and want to make sure that it doesn't become an issue. So I don't know if that's a good answer or not. It's know about it, but it's not an issue in Tennessee.
Well, that seems like a great answer to me, and I'm glad that that hasn't been an issue you've encountered yet. How about the panelists from California? Do either of you want to speak to that question?
I'll start. I would say that care coordination is still an ongoing challenge. Schools are in session, not all year round. There are year-round schools, but they take breaks just like more traditional models. And so continuity of care during summer and winter breaks or other school holidays is something to take into consideration that we're really trying to think through. Coordinating care so that our managed care organizations know what services their members are getting at school, and vice versa, so that the schools know what services the child or young person might be getting from a community-based provider is also important, so that there's not a duplication of services. And I know that the question is, you know, how do we prevent plans from deciding that there's a duplication? And like Tennessee, we've also, for this new program, not allowed our managed care organizations or commercial health plans to require prior authorization. But I think there's still that kind of idea of a more coordinated care delivery system, so that all of the providers who are delivering care are aware of the other services that are happening across the delivery system. And it is a challenge. So we're thinking about, you know, things like consent protocols and how we share data and release information amongst all of the, you know, players, the LEA, the managed care plan, the TPA. We're thinking about, you know, those community-based providers and what role they have to play in the coordination of care. While they might be working with the schools, they may also be network providers of our managed care organizations. And so what role do they have in terms of care coordination and responsibilities? So I think these are all really important questions to consider. And, you know, we don't have all of the answers just yet. It's a big, complicated system, but I do think that you know, we are actively thinking about how to resolve some of these challenges so that we can really have a member-based care approach to school-based services.
Thank you, Autumn. We have another question that's intended for all of our panelists. I'm wondering, Sherry, if you might want to take this one. It is, what are common billing errors that we should look to mitigate as we plan to implement?
I think the crux of all things, and I use this from my hospital days, is that if it's not documented, it didn't happen. So I think you have to, as a practitioner, make sure that you document to the degree that you would in a hospital. Sometimes educational systems don't see that. So number one, is it medically necessary? That's the first thing that has to be documented and substantiated. Is there parental consent to deliver the services? Are the services within a healthcare plan or in the IEP? In California, you know, treatment services have to be delivered within the realm of a treatment plan. And then is there an evaluation mechanisms? Somebody's having flashbacks from nursing school. That's right. So the other thing too is that, you know, are you documenting to what the medically necessary services are, and is it in a proper and efficient use of, you know, taxpayer dollars as outlined in the the Medi-Cal regulations? So really, I think documentation is critical, and making sure that also student response. You know, how did the student respond to treatment? So there really is a repertoire of that information. We also have imbued in our system documentation support. And we did that through a focus group of clinicians to make sure that we captured the information, so that as people go through the billing system, it is a response, a prompt that's already set in that system to minimize that oversight.
Thank you, Sherry. I think we have a minute or two left. I don't know, Sean, if there's anything from Tennessee you want to add here, or we can just wrap up.
I just very quickly, it's that timely filing was a common error for, denial error for us. And so one of the ways we fix that, because the other things that, I think California looks at, we don't look at on the front end. So it's like we do the retrospective audits. And so we would find those things on the back end. But timely filing was an issue, especially because, our LEAs have to have that doctor's order. And so they wouldn't bill until they got the doctor's order. But 2 years ago, legislation passed where the doctor's order was required, or an alternative to that was the skilled therapist referral, which would be like an OT, ST, PT. And so that has really helped with LEAs being able to get an order or the skilled therapist referral and not have to wait for that information, which has improved the timely filing and decreased those denials.
Thanks, Sean.
Michaela, I want to add one more thing too, is that, there is a requirement of a compliance plan under the Affordable Care Act. And so that's the other part that we've done, at least with my own LEA, is looking at what are the high risk, moderate risk, and low risks for audit findings based upon the regulations. And so really helping provide that feedback early on to LEAs about, look, this is not meeting what needs to be met, and you need to move forward. Because we want to make sure that there is reimbursement, because when not, it compromises care. So that's really another element that we've put into place in our own LEAs, with our own LEAs.
Thanks, Sherry. That's an important point, and thanks for adding that in. We have received some really great questions today in the Q&A. I wish that we had time to get through all of them. We've answered some of them through the chat, and we'll be taking a look at everything that we received, and we may be we'll be responding through the help desk to the questions that we didn't get to today. So thank you, everyone. I just want to say a huge thank you to our panelists today. It was great hearing from you. I think it really brought this topic to life and provided some great examples of what you've been doing in your own states. So we really, really appreciate you. Thank you so much. Before we wrap up, I just wanted to remind everyone the next virtual event or virtual meeting will be on June 13th. The topic will be Introduction to the Readiness Checklist, which is a comprehensive tool to assist with school-based service state plan amendment submission and compliance. So please join us for that event. Thank you all for taking the time to join us today. We hope that you learned something. We will be making these slides available once they are ready. And again, we'll be responding to questions through the mailbox. So thank you all, and I hope you have a great afternoon.